All right, hey everybody, this is Dr. Lewis here with Dr. Michael George at KSF Ortho. We wanted to make a quick video just about some relevant things going on in the area of orthopedic medicine, pain medicine. So just to give you a little bit of background, again, my name is Dr. Taylor Lewis. I'm one of the pain medicine doctors here at KSF Orthopaedic with a little bit of subspecialty in cancer pain after training at MD Anderson. Dr. George here is one of the partners at the practice who primarily specializes in knee and shoulder surgery with an emphasis on sports medicine throughout his career, both in training and his professional career. He's been part of several sports teams as well as the professional rodeo as a consulting physician and providing expert medical analysis for injuries or any kind of those sorts of things for the likes of the NBA as well as the NFL. So piggybacking off of that, after the Super Bowl weekend recently where Tom Brady won his 6th Super Bowl, I believe, he did have to actually have his knee cleaned up. And Dr. George and I were talking about it in clinic, and we wanted to shed a little bit of light on what kind of procedure that might entail and kind of branch off and talk about some other various topics. So Dr. George, what can you tell us about what happened with Tom Brady?
Yeah, you know, the details are always vague when these professional athletes have their surgery, and there's HIPAA issues and things, but that is the same knee that he had his ACL tear on. And so initially they said it was just going to be a cleanup, but then they said it's more than a cleanup. So what does that even mean? What does a cleanup mean? Well, there's a lot of different reasons why you can have a knee scope. So the most common reason by far is a tear in the meniscus. I'll show you on the knee model. The meniscus is the cartilage pad. I don't know if you can see it on the video, but that's the cartilage pad. It's a flexible cartilage inside the knee. There's medial meniscus and lateral meniscus on the inside and outside part of the knee, and those tear not infrequently. So usually it's a twisting injury, but it can be just wear and tear where you get tears in there as well. And a scope is 2 little poke holes in the front of the knee, and we work with instruments the size of a pen and trim out the torn part of the meniscus. In younger people, if they tear in a certain way from an injury, often it's combined with an ACL, you can tear a big chunk of the meniscus. And if it's a big, healthy chunk, then you can fix it with stitches. But that's only in a younger age group and in a specific kind of tear.
Okay. And not all of us are Tom Brady, so what kind of, it seems to be a fairly common injury that can occur in just an everyday population?
For sure. It's very common, all different ages, from teenagers all the way up into your 80s, you can tear the meniscus. So other reasons for knee scope. So the meniscus is by far the most common. You can also have loose bodies where you have an injury and a piece of cartilage is floating around in the knee, and then we can go in and take that loose part out. That's most commonly what they're talking about when they're talking about a clean out. So clean out usually is there's loose particles floating around, maybe meniscus tears, and you're just cleaning things out and trying to make it so that there's not anything floating around anymore.
Okay.
But generally for things like arthritis, where there's general wear of the cartilage, and the cartilage is, when we talk about the cartilage, generally the meniscus is a specialized cartilage, but when we're talking about the joint cartilage, we're talking about the shiny cap on the end of the knee. And so when you have arthritis, it really doesn't help to do a clean out, because the problem with arthritis is that cartilage has worn away. And so doing a clean out and cleaning up loose fragments doesn't regrow that cartilage, so it doesn't really help. Now it's a different situation if you have, say, a young athlete who has an injury and they twist their knee and they knock a piece of cartilage off. That's a totally different situation than somebody who has arthritis everywhere.
So most of the arthritis that we're going to be talking about, especially in our older populations, this is what people refer to as just bone on bone in their knees.
Bone on bone, that's right.
So take me through the treatment process for these patients that you might employ in the clinic here with regards to, we can talk about injections and whatnot, but also are there arthroscopic procedures available for bone on bone arthritis, or are we talking about a knee replacement?
Yeah, so as far as arthroscopic procedures go, for arthritis, so where the cartilage is just completely worn out, there's really not an arthroscopic procedure. In those situations, and you can tell if someone has arthritis by x-ray. Sometimes you need advanced imaging like MRI, but usually on x-ray you can tell. For those people, the only surgical option is either a partial or a total knee replacement. I mean, that's kind of what it comes down to. There's different things, osteotomies where you can realign the bone, but once it's bone on bone, then it's non-surgical treatment, which you're going to talk about. And then if the non-surgical treatment fails, then it's a knee replacement. But for younger people, so say you don't have bad arthritis, say you're a young person, a young athlete, and you do knock a little piece of cartilage off, then your cartilage is otherwise good. You just have a hole. And so what do we do about that hole? Well, if you're having continued pain and you end up needing surgery, there's a couple different things that we can do. In the past, we used to do a microfracture. So, and still there are some indications for microfracture, but microfracture is where arthroscopically through 2 little poke holes, we poke holes in the bone to make it bleed and bring in new healing cartilage. It's called fibrocartilage. Okay. The problem with fibrocartilage, it's thin, it's weak, it doesn't last forever. So the results of microfracture, initially they can be okay, but then after a few years they start to deteriorate. So then there's a couple other ways that you can actually regrow healthy, we call it articular cartilage or hyaline cartilage. And so the 2 main things are a thing called autologous chondrocyte implantation, where in a 2-stage procedure, we take a sample of cartilage, send it off to the lab, they regrow a sheet of tissue, and then in a second procedure, you sew it back in to cover it up like a patch. The problem with it is it's a 2-stage procedure. So in my practice, most patients don't want that.
Right.
But the other thing that you can do that I do not infrequently is a thing called Osteoarticular Autograft, or it's often called an OATS. OATS is OATS.
Yep.
Osteoarticular Transfer System. So what that means is you take a piece of bone and cartilage from one area where you don't need it as much, and you plug it into the other area. It's kind of robbing Peter to pay Paul. But the newer way to do that is with an allograft. So instead of taking your own cartilage and plugging it into the defect, you can take cadaver bone and cartilage, which has the similar properties to your own, and it's already prefabricated, pre-measured, and you can plug it in. The great advantage of that is you can fill any size of defect without worrying how big of a hole you're creating, because you're not taking it from yourself, you're taking it from the cadaver bone. And I like that a lot. You know, that's a very good surgery. Of course, only if you really need it,
Right.
and only in the right indications. But that's a really good advance, I think, in orthopedic sports medicine.
Before we hop into kind of my role here, just for everyone watching, when we talk about arthroscopic procedures or knee scopes, whether it be for a clean out or maybe a little partial meniscal repair, what kind of recovery time are we looking for these patients?
That's a good question. So depends on what we're doing. So if it's just a clean out, so say it's a loose body or we're taking out a meniscus tear, that's generally, it's outpatient surgery. It takes 30 minutes or so. You're walking on it immediately. So maybe crutches for a day or two, but we want you up and moving because part of the rehab is regaining your mobility. We do therapy right away. It's 2 to 3 days a week, and total recovery generally is about 6 weeks.
Okay.
For those cartilage surgeries that we're talking about, replacing the cartilage, whether it's the 1-stage, 2-stage, whatever it is, and of course every situation is different, but that we're going to protect you a little bit more. So that we're going to keep you on crutches, partial weight bearing for 4 weeks, and that's more like a 3 to 4 month recovery. Okay. So that's a bigger commitment.
Right.
Yeah.
And then same thing, what about for just the open total knee replacement?
Total knee replacement. So that is obviously a bigger surgery. It's an open surgery. There's more. There's just more involved. There's more bone work, and so that's going to be a much longer recovery. So that's a walker, depending on the person, for anywhere from 1 to 4 weeks. Lots of therapy. Really important. Generally, for knee replacements, I always tell patients by 3 months you're better than before surgery. 6 month total recovery.
Mm-hmm. And just coming from an anesthesia background, most of, depending on the patient and their comorbidities, but majority of these procedures can be done with just a spinal or some kind of regional technique.
Yeah, I mean, things keep getting better and better, right? So the anesthesia just keeps getting better. We're able to do it with smaller incisions, less muscle injury, shorter hospital stays. All these things are getting better and better, and they continue to improve every day.
Mm-hmm. So, and then just kind of continue that conversation on where I might fit into this kind of the care of these patients are sometimes they may come to see me initially and they know right off the bat they may not want surgery, or they might not be surgical candidates due to issues with their heart or their lungs or other organ systems. So I can come in and help with my expertise in medication management and knowledge of different types of medications. Usually for patients with bone-on-bone arthritis, arthritis is just another name for inflammation, we like to look to anti-inflammatory medications. So think about ibuprofen, Tylenol is one. There's some more exotic ones that we can prescribe. We have to go to the pharmacy and pick them up. Moving on to the next kind of step in the algorithm, we talk about instead of taking anti-inflammatories through your mouth in the tablet form, we can inject them directly into that joint space and have more of a precision or targeted approach, again, limiting any side effects that might come with these medications. These steroid injections are something that we can do, every few months, just to make sure that we're not giving your body too much of that steroid, because a lot of the medications we do give can come with some side effects.
Yeah.
I did want to punt over the topic of viscosupplementation to Dr. George here, because that's, in my mind, I kind of equate it to the Ferrari of steroid injections, where it's some very unique biological molecules that can help prolong the lasting effect you get from these injections.
Yeah, so viscosupplementation is a general term for a variety of gel injections, and the main component of the gel is hyaluronic acid. So hyaluronic acid is the main component of healthy joint fluid. And so when you have arthritis, there's particles of cartilage floating around. It's just generally a negative environment, and so that hyaluronic acid level goes down. And so the idea is to refurbish the hyaluronic acid level. And there's a variety of different companies that make them. Sometimes they're single shots, sometimes there's 3 shots, and that may be patient or doctor preference. But they all kind of work about the same. And generally they work in about 70% of people. So 70% of people get improvement. The other 30% maybe say, oh, that didn't really help as much. But if it works, it can be repeated up to every 6 months. Or more accurately, the insurance will approve it every 6 months. So I did want you to, if you could talk about different types of injections that you could do, whether it's stem cell injection, PRP injections, and also I know you do genicular nerve blocks, which can help a lot of people. If you could also mention, does insurance pay for it?
Right, so when we talk about PRP or platelet-rich plasma, as well as stem cell injections, these are, to stay on label here, a bit more investigative modalities of helping relieve any kind of joint pain you might have, particularly referring to the knee. So this is just a way to use, human-derived components to generate some kind of regenerative process, whether it's taking your blood and spinning it down to take a certain portion out of it. That's referring to the PRP, or when we talk about stem cells, sometimes we refer to that as amniotic-derived tissue. That's where we are just taking cells that have not really matured into their form yet, that they would in your body over time, and we're hoping that by putting them in that joint space, they can slowly regenerate any kind of helpful cells like a cartilage cell or the hyaluronic acid we speak of.
So what's your algorithm? So say you have a patient who's either not a surgical candidate or they just don't want surgery and they've had a steroid injection. This is probably a common thing that happens, right? They've had steroid injections, maybe they've had visco injections. They come to you, they say, Dr. Lewis, my knee hurts a lot. I know I need a knee replacement. I'm not healthy enough for it. I don't want it.
Exactly.
So take us through, how you treat that patient.
And that's a great question, because it's a patient that I see every day. You more so than me, but if a patient is coming to me with just the first visit and they're having knee pain, obviously we're going to start as conservative as we can at first and then work our way up the ladder. We're going to get some x-rays, we're going to start physical therapy, probably start an oral anti-inflammatory medication like an ibuprofen or the other ones that I mentioned before. If we're still not getting any kind of improvement, then we look towards just a simple intra-articular steroid injection. And if we get good relief with those, if you need to get 1 or 2 a year, I consider that a very good treatment. If we're starting to get limited response to those intra-articular steroid injections, that's when we move to the viscosupplementation that we've talked about. And you could also consider the PRP or the stem cells. Just to kind of backtrack, insurance usually isn't going to cover those, the PRP or the stem cell treatment. So that's usually going to be a big out-of-pocket.
They do cover the visco.
Yeah, they do cover
generally,
the visco.
Most insurance. Sometimes things change.
Yeah. So another fun part of being a doctor.
Yeah.
And then after we talk, if we go through the viscosupplementation and we're still not getting a response, that's when a patient might be hopping back and forth between myself and Dr. George, where we've done pretty much all of the injections that we can, and now it's coming to the point of, is surgery something that is needed for this patient? Are they a good candidate for the surgery? Is the surgery, is a knee replacement, for example, something that they want? If they're leaning towards, yes, I want to get a new knee, put the titanium in, then they're going to go see Dr. George, and he's going to take great care of them. If there's someone who may be a little bit more ill or has a lot of breathing or heart problems, and they may not be able to, cope with the post-surgical process and participate with physical therapy in the right way, they can come to me for some alternative options. The one in particular I'd like to talk about is called the genicular nerve block, and this is where using an x-ray machine we identify 3 spots around the knee joint. There's 2 on the femur and 1 on the medial side of the tibia, and these 3 nerves essentially supply the sensation inside of the knee joint. And by using needles and x-ray guidance, I can come in with it's usually a 2-step process. The first step will be just injecting some numbing medication and a little bit of steroid, and we just hit the off switch on those nerves. Even if it's for a day, hopefully it's for a few months, we can see if we get any good relief with these patients so that they're able to continue their daily activities and maintain their functionality, because that's the most important thing. If that is successful, then we can submit to insurance again for what we call a radiofrequency ablation, and this is where we come back and do the same exact procedure, but instead of injecting medication at these 3 spots, I heat the tip of the needle up that I'm using, and it provides a kind of a lesion, as we call it, and singes the nerve. Now, it's not permanent. It's not going to damage the ability or hinder the ability for you to move your knee. It's just going to turn off for a longer amount of time the sensation within the knee joint. So this can be done preoperatively if they're not wanting to have a knee replacement, or even afterwards if we have a knee replacement and there may still be a little bit of residual discomfort. This is something that can easily be pursued after the knee replacement.
So a couple questions that patients ask me sometimes, and I don't know the answer.
Yeah.
So one thing they ask is my knee going to be numb? Another is, because I don't have feeling, is my knee going to be unstable?
Mm-hmm. So the knee itself may have some areas of numbness, in particular with the first injection, since we do put a little bit more of the numbing medication around the area, but long story short, it shouldn't be a numb knee. You should still be able to run your fingers along the side of your knee or on the inside and outside border and be able to sense that you're touching yourself. Now, it may be slightly altered, but it's not going to be absent, or it shouldn't be. As far as the stability of the knee, my answer would be no to that as well. So just because we're turning off the pain sensation inside the knee joint and the capsule itself, if your knee is going to buckle for any reason, you're not disturbing the receptors that are responsible for that sensation as well. So you may be able to sense your knee is buckling, but hopefully it won't be as painful as it might have been in the first place. So.
That's good. Well, we covered a lot.
I know, we did. Yeah, sorry.
That's
so,
good.
Thank y'all for tuning in. We're hoping to maybe just continue these kinds of, I'll say lecture series, every few months and touch in on important topics. If you guys feel like there's a topic you would want us to cover in the future, you can drop it down in the comments section below. We'll put this video on Facebook and Instagram. And if your knees are hurting, come see us.
Yeah, ksfortho.com or 281-440-6960.
All right. Y'all have a good day.
All right.